today is to understand the clinical features of two common neurodegenerative conditions, which are Parkinson's disease and Alzheimer's. What we want to do through these two conditions is really to allow you to understand what the neuroanatomical relationships and the neurophysiological changes are that underpin these two conditions. So we really want you to connect what we do in our day-to-day in the clinic to neuroscience, which I think is the goal of the session. Most importantly, we want you guys to have fun. We certainly do not expect you to have absorbed all the information that we sent you prior to the session. And we hope that this will be a way for you to get a little bit more of a feel for what neuroscience is in the clinic. Now, I think throughout the presentation, we want this to be as interactive as it can be, and please feel free to use the chat to raise a hand if you have questions. We're very happy to slow down some of the presentation to best fit your needs. The first part of the presentation will be led by me, and it will be on Parkinson's disease. You may have seen a video that I sent you guys. If not, we're going to go ahead and just start with a video of what a patient with Parkinson's looks like. And this is really something that we do all the time in the clinic, especially in the movement clinic. Video is a very powerful tool because it allows us really to understand what both the patient's experience is and what their main symptoms are. As we look through this video, what I would like you to pay attention to is whether you think there is too much or too little movement, whether you think these movements are voluntary or involuntary, and also take a look at what it is that moves. Is it the hand? Is it the foot? Is it the face? And finally, just give us an idea of whether you think the movement is fast, is slow, is random, is regular. Certainly, we don't expect you guys to get the diagnosis right or read the phenomenology of the movements right, but rather we're more curious about what your own words for this presentation would be. So I'm going to start with the video. Please let me know if you cannot see it moving. And I've also left the QR code on the left that you can use to then form a word cloud. We're going to try it twice. I'll have another slide where we can actually form the word cloud to have an idea for what your feel for what's going on is. And let me know if the video doesn't play. And you may also use the chat to kind of point out what you see. You may see that some parts of the body are moving. This is a helpful zoom. Read trembling of the hands. I would absolutely agree with that. Hai is saying it's involuntary. And that's a great point, right? It looks involuntary. A pearl here is always to ask the person, right? It's something that we may not be thinking about because it seems like almost an intrusive question to ask, but it's very important to ask them because some movements may be voluntary, some may be involuntary, some may be habits, but you're absolutely right. In this case, I would agree that there is a trembling of the hands. I would agree that it's involuntary. And then if you pay attention to the other side, there's something else that was going on right there. Now the examiner is trying to have the patient tap their fingers. And I'm curious to see what you all may think about the speed of these movements. Is it the type of speed that you would see would commonly see? And I think if you all want to participate in this and scan the QR code, you can just write just a one-word answer for what you see in the video. Let me know if the QR code doesn't work. Otherwise, I see some other responses in the chat, so maybe we can use that. I read here involuntary movements and trembles and rapid shaking. I think overall that's a very good summary. And you guys are exactly right. So you absolutely caught the oscillatory shaking that some of you wrote as trembling. The word that we use is tremor. And something else that I was trying to get at is that if we actually look at the patient's facial expression, it's definitely not as lively as we'd like it to be. And that's hypomania. And that's one of the features of that we'll talk about in a second of Parkinson's disease. And that really means that the face is not as expressive. And another term for this is masked faces, meaning that the face is not as expressive. And finally, when the patient was tapping their fingers, there was a slowing of the finger taps. So overall, all of this is consistent with the diagnosis of Parkinson's disease. There are other features that we should examine, of course, but just to give you an idea, the slowness and frequently also a resting tremor, meaning a tremor, especially of the hands and then the feet at rest, is what raises a concern for Parkinson's disease. Before talking about Parkinson's disease per se, I think you can all agree that the issue that was going on in the video was some kind of trouble with movement, too little movement and too fast a movement with the tremor. Let's take a step back then. Let's ask the question of how it is we move. And movement is really dependent on an area of the brain. As you can see here, this is a brain, and you can see that there is a specific area. There's the precentral gyrus. This is the name that you don't need to memorize, but it's a gyrus of the brain. It's a part of the brain that um, um, is tasked with generating movement. That's where your voluntary movement comes from. And it's also organized in a specific manner where certain parts of the cortex are devoted to different parts of the body. In other words, if you want to move your mouth, then this will be the part of your motor cortex that will be activated. If you want to move your hand, this is another part. And it goes without saying that up here you have a cartoon of which parts are moving what. This is not what the brain looks like on the surface, but it's a good representation to understand how the brain is organized. Now, the brain then has a very long series of neurons that go all the way down to your spinal cord. And that is where your first neuron kind of communicates to a second neuron, and the second neuron will then go to the muscles and move the actual muscles. So this is a message that goes all the way from the brain all the way to the spinal cord, and then from the spinal cord to your muscles, and that's how movement is generated. Simple enough, right? Now, this is not where Parkinson's comes from, though. If you were to have a weakness of your motor cortex, you wouldn't necessarily have the slowness you saw. Rather, we would have frank weakness. And this is something you may see, for instance, in a stroke. The patient is weak. You ask them to move that arm, and that arm will not be as strong as you. And they may even be unable to lift an arm, and the arm may drift down. This is not where Parkinson's comes from. It's not the slowness that we would see in Parkinson's. So where does Parkinson's come from? Now, the story of movement, I sort of simplified it so far, going from the motor cortex all the way to the muscles. And this is part of the story. But truth is that if you think about the complex movements you do on a day-to-day, if there are pianists in the group, you know how refined those movements can be, even tennis players, all of the movements that we do are much more complex than simply moving a single muscle. To capture the full story, you can think of the brain having feedback mechanisms. And by this, I mean the motor cortex is sending a message to the muscles, but in parallel, other parts of the brain get a CC, They get a communication that they can then act on. And there are two parts of this story. One part is the brain, or rather a circuit from the brain trying to understand what to do and what not to do. The second part is one that goes to the cerebellum. You may have heard the cerebellum. It's also part of the central nervous system, and it's the part that determines timing of movements. So one part sort of suppresses or activates specific movements. The other part with the cerebellum drives timing. And what we're going to focus on today is the basal ganglia. So again, your motor cortex will communicate to the muscles, but in parallel, the motor cortex will also communicate with a part of the brain that's tasked with either inducing that movement or stopping the movement. In other words, your cortex will send a ton of information and will have a ton of possible movements, but it is the basal ganglia that then allows us to decide whether movement will take place or it will not take place. And this is where the basal ganglia are. You see, up here is the motor cortex that again communicates with your all the way to your muscles, but there is a part in the what it's still in the deep part of your brain that will then determine whether the movement is taking place or is not. And to do this, you see that, and just to orient you here, this is us looking at a cross section of the brain from head on. And these are the nuclei that compose the basal ganglia. And you have two different pathways. One that's saying, let's go. One that's allowing the movement from the motor cortex to reach the periphery and reach your muscles. And another part's to say, no, let's stop. And this is a tug of war between two different populations of neurons. And when you have dopamine, that you may have heard this term in the past as the neurotransmitter that's driving motivation. When you have dopamine, the pathway that says let's go is winning. And if you don't have dopamine, on the other hand, what really goes on is that there's, on the one hand, there's less motivation. On the other hand, there's less ability to start movements. Dopamine, you may have heard again as the kind of neurotransmitter that's driving motivation. And dopamine, it comes from an area of your brain, of your brain stem rather, which is right here. And it's called the substantia nigra, known as the black substance. And this is where dopamine is housed. And this is also where the pathology of Parkinson's disease comes from. Again, dopamine is produced right here in this area of the brainstem called the black substance because it looks dark, as you can see. And what really happens is the following. So let's put it all together. We talked about movement starting from the cortex and movement being either inhibited or activated by that area of the brain called the basal ganglia. With one pathway, which is the direct pathway, movement will happen. With the indirect pathway, movement will be suppressed. What then happens is that to shift the tug of war, you will have dopamine that's driving movement. But if you lose dopamine, the tug of war will be won by the part of the basal ganglia that wants movement to stop. So in Parkinson's, you have the degeneration of the area that's producing dopamine. And as a result, you'll have less movement. And less movement will then be seen as loss of facial expression, slowing down of the movements, what we call bradykinesia, which is a super fancy word to say slowing of the movements. which can be slowing of those finger taps, slowing of agility. Patients may have trouble walking, for instance. And finally, tremor. And all of these together are known as Parkinson's disease. Now, just one more question that I may have for the group before I switch it to my co-host today, Chris. If we were to put it all together, Parkinson's disease is due to loss of dopamine and degeneration of the substantia nigra and less movement. Now, I'll open the floor to the group just to make sure that we're on the same page. What do you all think could be a good way to treat Parkinson's disease if you were to think about it as a neuroscientist? And feel free to either use the chat or raise a hand or just chime in.
I think we've got a hand raised. Stephanie, go ahead.
Are there medications? I always get this mixed up, so Professor, please forgive me. There are medications that are antidepressants. Do they help the body produce more dopamines or less dopamines? Because they're antidepressants.
That's a great question. I'll correct you on one thing, and what I'll correct you, please call me Mattia. But so it really depends. There are some antidepressants that act on dopamine. I will say there are some antipsychotics that can be anti-dopaminergic, although that's a little bit more complicated a story. Most of antidepressants, the classic ones we think about, act on serotonin. You're right that there are a few that act on dopamine.
Sorry. Yes. Serotonin.
Serotonin is also an interesting neurotransmitter, but it's certainly one that we also target in Parkinson's because Parkinson's has depression as a possible symptom, but that's not part of the motor part. But you're right, it's another neurotransmitter. Now there's someone that chimed in and said levodopa, enhancing dopamine production. Those are both correct thoughts. And you're right, you have loss of dopamine. You give something that can make dopamine. Now, Amna said levodopa, which is the precursor to dopamine. Enhancing dopamine production would also be an interesting way to target it. In a way, you could think of levodopa as giving you more fuel to make dopamine, so that enhances it. I don't know that we're quite there in terms of enhancing dopamine production in the way of recovering from degeneration of substantia nigra, but that would be exactly right. No, that's great. Any questions so far, guys? Otherwise, we can shift to the second part of the presentation, and then we'll have plenty of room for questions toward the end. And I'm happy to go back to some of the parts if something wasn't clear. All right. Well, otherwise, I'll shift it to Chris.
All right, everybody. Oh, we got two more comments here. So before we shift gears.
Oh, yeah, please. Thanks for... How many different degrees are there in Parkinson's? That's a good question. Hi, if you feel comfortable, would you be able to tell me a little bit more about your question so that I know how to answer it? Because I have a few ideas for where to take your question, but I want to make sure that I'm understanding your question correctly.
So specifically what I mean is how there are different severity levels of different diseases. How many different levels of severity are there, and are they identified in different ways?
Right. That's a great question. So I'll sort of take your question in two different directions. The first one is that I gave you somewhat a simplified version of what Parkinson's looks like. You'll see there was this wonderful cartoon that was released on JAMA, I believe, a couple of years ago, where they were really focusing on the fact that the picture of Parkinson's disease that you see in the old textbooks is really simplistic because there are so many different ways Parkinson's can present with. Here you have, for instance, a runner who presents with a foot, if you will, it's called foot dystonia, but it's sort of a cramping and posturing of the foot that can be an initial presentation, especially in young people with Parkinson's. There's some other people that can present with the tremor and the slowness, but there's also people that don't present with tremor and may present with slowness and a lot of rigidity, stiffness in the muscles, right? And you can certainly appreciate here that this patient here, who seems to have trouble walking independently and is using a walker, is very different than the patient on the left. So by and large, I think we divide Parkinson's into tremor predominant, when there's tremor that's driving most of the story, to rigidity and lack of movement predominant. That would be one way to parse it out. Another way to think about it is exactly how much is the patient being affected, right? So patients may at the start have only half the body that's affected prevalently, and then as the disease progresses, both sides can be affected, and then further along the years, there can be some loss of balance, and there can be some requirement for assistive devices like a cane, a walker, a wheelchair. So that can be the spectrum of severity, if you will. I will also say that there are many other things about Parkinson's disease that we cannot really touch on today, but that can be really bothersome to the patient, including low blood pressure, including cognitive side effects. And I think this will be a good segue to what Chris will talk about in terms of cognition as well.
Thank you.
And yeah, I hope that answered your question.
Yes, it did.
And then there was one great question about the difference between paralysis and Parkinson's. So when you talk about paralysis, we mostly talk about weakness. And I think of paralysis as really that original message that I was telling you about that goes from the motor cortex to your muscles. So that's a form of weakness. Whereas in Parkinson's, what's really missing is this communication with the basal ganglia. It's not completely missing, but it's affected. And that's where you get the slowness. So the main difference is that if you were to check someone's strength and they're paralyzed, they would be weak. Whereas a patient with Parkinson's is not weak, but has a lot of trouble moving at the appropriate speed or maintaining a certain movement. Would physical therapy or speech therapy help slow the progression of Parkinson's? Does Parkinson's get better or worse over time? That's a great question. I will say we have currently no medications to slow the progression of Parkinson's. I will say though, we have pretty good data on exercise being to some extent neuroprotective. So that's recommendation number one when we have a patient with Parkinson's. On top of that, physical therapy and speech therapy, while they may not necessarily slow the progression of Parkinson's, they're extremely important for the quality of life and safety. And they can certainly recover some of their strength, some of their mobility, if you will, and some of their speech with these interventions. And then another question was, I personally believe the best way to treat Parkinson's would be exponential dopamine production and following neurotransmitter aids guidance in terms of emotionality, learning, and movement. Yeah, I mean, if we could recover dopamine production, that would certainly be a great way to approach Parkinson's. And then it it's also interesting what you're mentioning about the neurotransmitter guiding emotionality, learning, and movement. You're exactly right in saying that dopamine does a lot more things to the brain um, than just movement, and certainly that's something that we also look closely to in the clinic. Um, And then another great question is, do we think it's physiologically possible to ever completely reverse or cure Parkinson's? Not at this point, but I would say it's certainly a hope from the community. I think the big hope from the community is to find ways to reverse the degeneration that causes Parkinson's and recover that lack of dopamine, and also to find what we call disease-modifying treatments, meaning treatments that can change the trajectory of the disease rather than providing ways to use the existing brain network to to um, um, to improve the patient's mobility, for instance. Um, Great question about how are blood clots in the brain related to stroke. Um, I think that's a great question, but maybe we can have a separate session on vascular neurology. But that's kind of outside of the scope today, but it is a really, really good question. All right. Please feel free to keep the questions coming. In the meantime, though, we'll switch to the second part of our session, and we can address some of the leftover questions on Parkinson's toward the end of our talk.
Thank you so much, Mattia, and thank you to the group. You all ask excellent questions, so please keep them coming. So we're going to switch gears just a moment, but I promise we'll come back to other sort of discussions of Parkinson's together at the end. I'm going to focus a little bit on Alzheimer's disease today. One of the other hats I wear is that I am one of our behavioral neurology fellows as well. And the reason we chose to speak about Parkinson's and Alzheimer's together today is that they're actually the two most common neurodegenerative diseases that you might come across. So before we jump into Alzheimer's specifics, I think just as Mattia beautifully laid out sort of how do we move, it's helpful to think about, well, how do we think about thinking? And for those of you who have taken history or philosophy, you might be familiar with Rene Descartes' very famous statement, I think, therefore I am. And so I couldn't help myself but put a little Rene Descartes cartoon in here. Bear with me. But before we get to the next slide, Mattia is very kindly going to be advancing them for me. I'd love to ask you all, back if you can, before we go to the next slide, I'd love to just ask you all, well, if I ask you that question, like, how do we explain the ways that we think, or do you have any framework or ideas about the different ways in which we think and how that might impact how we move throughout the day? It's a little bit of a complex question, but I'd love to hear your thoughts. For example, one of the sort of things that comes to mind for me as we're talking over Zoom is that language is really important, particularly when we're communicating through screens and audio. So that's sort of one way in which we think is to process language and create language and interpret language. What are some other sort of domains of thinking or cognition? Things that you might have to process throughout your day to move through the world.
Hey, I think someone just asked if you could repeat the question.
Sure. So what I'd love to pick your brains about is sort of different ways that we think throughout the day to kind of boil it down. For example, one way in which we think throughout the day is thinking about the words that we want to say, understanding the words that are said to us, and sort of processing language in a way that facilitates conversation and understanding. So language is one really important domain of cognition. Hi, I see you have your hand raised. What comes to mind for you?
The first thing that comes to mind for me when we think about thinking, I feel like emotion plays a big role in how we think and our actions. So, like an example would be if you're talking to someone about a movie and they mention your favorite movie, the first thing you're thinking about, oh my gosh, I love that movie. So, overall, you'd be happier, and that would trigger what your response would be to when you're in a conversation.
Absolutely. So emotion plays a huge role. We have, as you just pointed out, emotion and memory can be very closely tied together, right? And we also have to be able to not only sort of interpret and move through our own emotions, but interpret the emotions of others. And maybe, what is it about our cognition that helps us to know, oh, hey, they're upset. I'm going to give them some space. Or, maybe I'll be a little bit more tactful in responding X, Y, or Z way. So definitely our social skills are a really important part of our cognition and sort of wrapped up with our emotional intelligence as well. Anything else come to mind? It's okay if not. Yeah, so Juliana and Maddie, yeah, so absolutely. So we have to sort of be able to depict different viewpoints throughout the day, whether that's what somebody is saying to us or sort of more literally visual information, right? So we're always having tons of visual information coming at our bodies in different ways, light, shapes, color, and we have to kind of put those together and say, oh, this is, you may not be able to see with the blurring, but this is my AirPods case. We also have to assign meaning to it, without sort of some background knowledge, this would just be sort of like a square-ish shape with some round corners. And I might not have like a meaning or a name for it, but I can describe what it is. So our brains are always integrating all of this information to help us say, this is my AirPods case and I need it to hear you right now. Excellent. So for the sake of time, Mattia, if you don't mind advancing to the next slide, you all have already done some incredible work identifying what we think of as cognitive domains. So anytime a patient presents to our clinic with a cognitive concern, one of the big questions we're going to ask is, well, what domains of thinking is that person having trouble with? What's sort of getting in the way of what they need to do day to day. And so you might, if you go and read about cognitive domains, you might see slightly different breakdowns than what I've included on the slide today. But these are the big categories that I like to think about and will hopefully be helpful to think about together. So first and foremost, attention. You've got to be able to pay attention to the things that are going on around you and focus in on what you're trying to sort of pay most attention to. For example, has anybody seen that count the number of times the basketball has been passed video? If you haven't, yes. So when I was in high school biology, I completely missed the gorilla in the background. So if that happened to you, don't worry. But basically, we have, as I described, we have all this information coming in to our brains all day, every day, and we have to be able to sift out what we need to sift out to pay attention to what we need to pay attention to. So that's one important domain that really affects everything else. Another domain is called executive functioning, and I think it's kind of hard to describe. So one acronym, or excuse me, sort of way of mnemonic that I was taught was SOAP. So sequencing, organizing, abstracting, planning, and problem solving. And those types of domains are sort of housed in the front of our brains, in the frontal lobes and what's called the prefrontal cortex. We already talked a little bit about language, and you already brought up learning and memory. And so oftentimes we have folks coming to us saying, I'm really having trouble remembering different parts of the day or different parts of the week, and that's causing me concern. You also brought up visuospatial processing, so that's definitely a really important domain. We talked about social skills and sort of social perceptions, and then sort of the last domain can be a little bit hard to conceptualize, but it's called praxis. And at its most basic level, that's basically our brain's ability to know how to do things. For example, my arm is strong, my motor cortex, that diagram that Mattia showed you going from the brain down into the rest of the body to control your arms and legs. I have to know exactly what I want my hand to do to be able to brush my teeth. And so knowing how to brush my teeth and knowing what my arm and hand need to do to achieve that is what we would call praxis. And I don't know if there are any awkward Yeti fans out there. I'm a big awkward Yeti fan, but I like this cartoon, not just several different cognitive domains. So the brain here is building a structure with bricks and mortar. And in order to be able to build that structure, he needs to have intact praxis. He needs to know how to use the tool, where to put the mortar. And on top of that, he needs to have his visuospatial processing intact in order to put all of those pieces in the right place. He has to be paying attention, and unfortunately, Hart isn't paying attention and knocks through the wall and puts all the pieces down. And then on top of all the things that Brain has to do to fix the wall at that point, he has to remember that the wall said plan, and he has to have some intact language to be able to write, read plan, and spell plan. And maybe it'll take some social skills not to take out on Hart the fact that Hart broke what he's been so long focusing on. So you see, right, that we're always using all of these different parts of our cognition throughout the day. And Mattia, if you don't mind advancing to the next slide. Awesome, thank you. So one important principle, and we've already seen this a little bit talking about dopamine and substantia nigra, is that each of these domains map to a different part of the brain. So every function that our brains perform and sort of express through our bodies tends to have a specific topography, or at least a specific network in the brain. And so that's true of cognitive domains. What I've shown you here, some of you, if you've taken neuroscience in any form or may have seen through this course already, what I've shown you here is one of the sort of classic schematics of language processing in the brain. This top square, well, you'll see something called Broca's area and something called Wernicke's area and some fibers connecting them. And we like to think of those areas as Broca's area is the part of the brain that helps you to express speech, make speech, and Wernicke's area is the part of the brain that helps you to sort of comprehend speech, and they're very connected. But what I've put below that square, you'll see there's a different diagram with all sorts of different colors. And I share this to make the point that we're always learning more about the networks in the brain. And oftentimes what we understand is still too simple. So this is from a paper that was exploring sort of different forms of language processing and how many other parts of the brain might be involved, or how much greater the space might be. I'm going to keep going, but before I do, may I ask any questions about anything I've said so far?
What's the Broca's area and the Wernicke area? What is the definition of those?
Yeah, so Broca's area is the part of the brain that we associate with expressive speech and language production. So my ability to get out the words that I want to get out. Whereas Wernicke's area is more of what we think of the receptive language area of the brain, the part of the brain that helps me to understand what you are saying to me and comprehend language. It gets a little bit more complicated than that, but those are sort of the two big buckets we think about as sort of expressive language and receptive language as it relates to these two areas of the brain. And then there's the fibers connecting them that help us to sort of integrate all of that information together. So how do we begin to understand how these different domains are working? Well, one of them is what our patients tell us, right? And one of them is what our patients' loved ones tell us, because oftentimes they may have some important insight as well. But the mental status exam, which is part of what we do in the office, really helps us to drill down on different domains. So I've put up on the slide here a couple different ways in which we might test different domains of cognition. So for example, what's your name? Where are we right now? Sort of your orientation to the world around you and to yourself. Spelling the word world backwards takes quite a bit of attention. And so I might ask you to demonstrate to myself that your attentional ability is intact. I might say, please spell the word world backwards. For a language test, I might point to my knuckles and ask you, what are these? And we would think about whether or not we're testing words that are really common in your day-to-day life and words that are less common. It's of course going to be a little bit easier for you to call to mind an object that you see all the time versus naming an object that you may not see all the time or think of the word all the time. For one of the best tests, in my opinion, is asking somebody to draw a clock for a number of reasons. So if you remember back to SOAP, that sequencing, organizing, abstracting, planning, problem solving, on top of being able to sort of visuospatially draw a clock, we have to have some abstraction of, well, what is a clock? And I have to be able to plan out how I draw my clock. I have to draw a circle. I have to put all the numbers in the circle. And then I have to be able to abstract, well, when somebody says, draw the time as 10 past 9, well, what does that look like on a clock and what do they mean by that? So it can give you a lot of really great information. Another sort of set of tests that you might do, I might give you 3 words to remember and ask you in a couple more minutes what they were. I might ask you to show me 2 fingers on your left hand, which would help me to understand that A, you're comprehending what I'm asking of you, and B, that you don't have any left-right confusion. And then finally, you'll see all these little bubbles on the side of the slide. And what I bring that to your attention just to show you one other way that we test visuospatial and executive functioning is to have patients complete a pattern. So you'll see that the first line goes from 1 to A, and then the next line goes from A to 2. And we might ask folks, can you complete the pattern? So we'd be looking to see, can they continue the pattern to 2A, or excuse me, 2B, B3, 3C, and so on and so forth. Any questions about this part so far? One of the things I think is wonderful about the mental status exam is I think of it almost like an accordion. You can go like however deep you want to go, or you can do sort of a select few maneuvers. And so oftentimes we might have patients go for several hours of testing if we really want to dig down into each of those domains. And so that's something called a neuropsychological evaluation. All right, Mattia, if you don't mind advancing to the next slide, please. So now we're going to dig into a little bit of a case. So a 72-year-old comes to your office, you guys are the neurologists, and she shares with you that she's had 2 years of memory concerns, particularly some difficulty remembering recent events and names of friends, but not the names of people who are really, really close to her. She also recently got lost in her neighborhood while driving, which was really scary. And she said, it was like the map in my head was gone. I suddenly didn't know where to turn. And her family's also started to get a little bit of frustrated with her because she starts to repeat information over and over again. So I know I've given you just a little bit of information, but what stands out to you? Does anything kind of ring any bells or feel particularly worrisome to you when you hear this story? Yeah, hi, go
It's a
ahead.
raised hand.
The first thing that came to my attention is that she remembered the names of her friends, but not her family, even though her family would probably be closer to her and, known her for longer times in her life. So wouldn't that hint that it's more long term than short term?
So hi, I apologize if I misspoke. It's the flip-flop. So she's having trouble with remembering her friends' names, but her family, she's okay. But you're right, that would be really concerning if, she's not remembering folks who are really, really close to her. Absolutely. And then I've got 2 messages here for getting lost in her neighborhood. Yeah, absolutely. And rapidly forgetting information. So before we sort of dive into the next piece, short-term memory loss, absolutely. So, folks often come to the clinic and they say, I'm not sure if this is a consequence of normal aging or if this is something more. And so we're constantly thinking about that question, and you all are pointing out some really important details that sort of make us suspicious for maybe something more, or at least we need to dive further, right? So just as Mattia, if you can advance the next slide, just as everybody said, she's having difficulty with short-term memory. She's rapidly forgetting information. She got lost in her neighborhood and having some difficulty with the names of her friends. And then on top of that, this has been going on for 2 years. So Mattia, if you don't mind advancing the next slide, please. Yes, exactly, Juliana. So we do a little bit more testing in the office to dig a little bit deeper. And I'll show you, these are just a snippet of some of the things we might do. So on the top row, what we have done in this case is we gave her 5 words to remember. And several minutes later in the test, we asked her, can you tell me what any of those words were? And I'll tell you, one of the important things to know about learning and memory is that we have to prove to ourselves that that information got in the first place, that somebody registered what you said. So when you gave her all 5 words, she was able to repeat them right back to you. But now, as you can see, that top row shows what she was able to remember without any clues. And then we gave different types of clues throughout the testing. And without any clues, she was able to remember yellow. But with category clues, for example, body part, type of fabric, vegetable, that wasn't able to bring any information to mind. Finally, with multiple choices, she was able to retrieve some of that information, but not all of it. And then as you can see on the beneath that part of the slide, we see her clock. And she's able to draw the circle, put all the numbers in the right place, but had a little bit of difficulty with 10 past 9. As we go left to right on the screen, there's that what we call trails testing again, that she starts off 1A, A to 2, 2 to B, but then starts to get lost, right? Starts to get focused on all of the letters, but forgets the numbers. And then finally, the farmost right side of the screen, you see an H made of little A's. And when you show this to her, she says, well, I see a little line of A's. I see a similar little line of A's, and so on and so forth. She then shows you that there's a very long line of A's, a couple more long lines of A's, but she's not able to see the forest for the trees. She doesn't see that there's an H made of little A's. So if we go to the next slide, revisiting those cognitive domains that we talked about, what is jumping out at you? If we had to choose which domains are affected for this particular patient, what do you think is affected in her case with the information we have so far? And feel free to put it in the chat if you feel more comfortable. Totally. Executive functioning, visuospatial, any others come to mind from what? Totally. So Mattia, you can go ahead and go to the next slide. You all nailed it. I completely agree. So if we go through the rest of the testing, we may find some other things here and there, but for her, we get these 3 domains sort of pop out, right? And so if we go to the next slide, this particular pattern of cognitive change hints at us that we have a growing suspicion for Alzheimer's disease. And I'll talk a little bit about other neurodegenerative diseases at the end. But this is the most common neurodegenerative disease or cause of dementia, I should say, in the United States. Age is the biggest risk factor, and it's characterized by episodic memory loss, meaning short-term memory, visuospatial difficulties. And then we didn't get into this too much, but word finding difficulty you can see early on. And what I would add to that, which this last bullet point gets at, is actually executive functioning can be a manifestation of Alzheimer's disease. And classically, it's been thought to be something that we might see more in early onset Alzheimer's, folks that develop Alzheimer's much earlier in their life, around their 50s and 60s, as opposed to later. But actually, there is some research emerging to suggest that folks who have Alzheimer's later in life may also exhibit some difficulty with executive functioning, which we certainly see in this case. And I just want to make a brief note about episodic memory loss, is that it's not unusual for folks in this case to have very intact what we call autobiographical memory, meaning early on in the disease course, they're able to tell you all about their childhood, all about their careers, and can really relate a great amount of detail, which that can be part of what's confusing about, well, I'm not sure if this is age-related cognitive change or if something else is going on. So Mattia, if you could advance to the next slide, please. So we talked a little bit about the substantia nigra and the basal ganglia as it relates to Parkinson's disease. And in Alzheimer's disease, different parts of the brain are affected by a different mechanism. And so what I've shown you here on the left side of the slide is an MRI of somebody who has Alzheimer's disease and an MRI of somebody who does not. And you'll notice, I wish I had my pointer here, maybe Mattia could circle the patient with Alzheimer's disease. Thank you for being my PowerPoint buddy here.
Can
We
you
can see
guys
your
see
pointer.
the arrow? Okay, great.
Yeah, so what Mattia is pointing to, these red areas here are a part of the brain called the hippocampus. And I'll show you a little bit more about the hippocampus in a moment, but it's integral in short-term memory particularly, but memory in general. And you can see that the overall size of the brain for the patient with Alzheimer's is smaller than the one next to it, but particularly those areas of what's called the hippocampus in the temporal lobe seem to be prominently affected. And on the right side of the screen here is a special stain that shows two of the protein abnormalities that are inherent and prominent in Alzheimer's disease, which is beta amyloid plaques, that big glom there of protein, which is extracellular. And then NFT stands for neurofibrillary tangles, which are intracellular. And together, these lead to the loss of neurons in the brain. And so if we go to the next slide, this is not a image modality that is clinically being used, but is being used in research. This looks for tau deposition in the brain as opposed to amyloid deposition. But what I wanted to show you here is that the pathology in Alzheimer's disease maps to the parts of the brain that we would expect to impact the functions that all of you have already identified on this person's exams. So in the amnestic Alzheimer's disease and the non-amnestic Alzheimer's disease, on the left side for C, amnestic Alzheimer's disease, we see that those hippocampi they're lighting up, right? They have lots of tau in that area, and we won't get into the complexities of that, but that's just to say we know there's pathology in the hippocampi. And then in the non-amnestic example, you see that there are other parts of the brain involved as well, particularly the back in the front of the brain, where we might have some executive functioning difficulty. And then at the top right part of that box, right under the words Alzheimer's disease, you'll see that the top of the brain and the back is quite bright, as in addition to the other sort of lower lobe. And that top back part of the brain, the parietal area, is really important for visuospatial processing. So you can see how this starts to manifest as some of the symptoms that we talked about so far. So Mattia, I know we're getting close to time, so I promise we're getting close to the end, but I wanted to share with you, we talked a lot about the basal ganglia and the networks involved therein. For Alzheimer's disease, a really important circuit to be aware of is something called the PAPES circuit. And this is a very complex network, but as you can see, it's involved with the hippocampus, and there's a structure that follows around to something called the fornix that communicates with the anterior thalamic nucleus, the mammillary bodies, and something called the cingulate cortex, which is that cingulum bundle. And we know that the hippocampi are impacted by Alzheimer's disease, and actually some other parts of the PAPES circuit are impacted by Alzheimer's disease as well. So that network starts to work less efficiently, less successfully. And this is the circuit that's really, we consider integral in memory and emotion. So it's not just the part of the brain, but the networks that are housed in or communicating with that part of the brain that ends up manifesting the symptoms that we see. So Mattia, if it's to the next slide, please. Now we're arriving at the end, and we'll want to make sure we leave some time for questions. But we've learned about two major neurodegenerative diseases today, which are very different in some ways, but also very similar. So they're both slowly progressive, and they are both characterized by irreversible loss of specific functions in the brain. But the way in which those functions are affected may be dependent upon, one, the type of protein that accumulates and where that protein may be most, for example, most likely to accumulate, or, for example, degenerate with the substantia nigra. We lose that, we lose dopamine, and we lose the ability to have that network communicate successfully, right? In Alzheimer's disease, we have those amyloid plaques, those neurofibrillary tangles. Those are accumulating in parts of the brain that are involved in the PAPES circuit or in visuospatial processing. And then we get episodic memory loss. We get difficulty with that spatial map in the brain, knowing where we are in the neighborhood. Conversely, with the substantia nigra degeneration, we get bradykinesia, we get rigidity, we get tremor. That tug of war between the direct and indirect pathways is compromised. So both disorders start with sort of from protein deposition and loss of function of a part of the brain, but because very different parts of the brain are impacted, we see different symptoms. I won't get us into too much of a rabbit hole, but just so you're aware, something that Mattia and I are both very interested in and learning more about is that we actually see that for some patients, these things crisscross. So you might see somebody who has both Parkinson's and Alzheimer's pathology in their brain at the end of life. But that's a really complicated topic that we'll save for another day. And just to make sure we have time for questions, I'll stop there. But thank you both, or thank you all so much for your attention. And just to wrap up again, symptoms are driven by the affected area of the brain and the networks that live in them. And there are lots of different neurodegenerative diseases that are different from Alzheimer's, different from Parkinson's, but they really start with the same principles. Something is affecting a specific area of the brain in a specific way, and that manifests with a specific constellation of either cognitive movement symptoms or all of the above. So thank you all for your attention. If you have any other questions, both Mattia and I'd be happy to answer them.
We have a raised hand, Nikita.
So what causes protein deposition? I'm guessing genetical factors could play a role.
Yeah, so that's a great question. In some cases, so just to sort of take a big step back, for whatever reason, proteins start to misfold and glom together in different ways. I think that's something we're still trying to understand, because we also know, and not to make things even more complicated, but folks who have healthy cognition, healthy movement through their lifetimes, if we bring those folks to autopsy, they've donated their brains for different reasons, we might find some of those protein depositions in the brain. And so there may be a component that might be part of normal aging, but something goes amiss such that we get more deposition, more pathology, more symptoms. And sometimes that's genetically determined. I suspect that there's probably a lot that we don't yet know about genetics, but there's also maybe some environmental factors as well, that we're always learning about nature versus nurture, right? And so I don't have a great answer for you. I don't know if Mattia has a better answer than that, but that's just to say that we have identified some genes that increase your risk for both of these conditions, but in many cases, it's not necessarily an underlying genetic mutation that we've identified yet. I don't know, Mattia, would you add anything to that?
Yeah, no, that's exactly right. There are some, there are these like cases and these syndromes that are genetic. Like there are some forms of familiar or genetic Parkinson's, for instance, where the cause is directly the excessive production of the protein that then causes the degeneration, right? And likewise, the same is true in Alzheimer's, but those are not the main cases. And then you have on the opposite side, you have cases like in what you may have heard of CTE, chronic traumatic encephalopathy, where repeated head trauma is then associated with protein deposition in the brain. But those are, you can think of them as sort of the pure versions of these neurodegenerative disorders. And most of the time, as Chris was saying, things are probably in the middle. And even, the patients with genetic syndromes, then with certain environmental factors, they may present earlier. So it's a spectrum.
And Haya, to answer your question about a diet in seed oils, I'm not sure about indirectly or directly linking. I haven't come across that information myself. But what I would say for, a question we often get is, so well, what should I eat? What should I do? How can I keep my brain healthy as long as I can in my lifetime? And certainly there are genetic factors that we're learning about, but one of the things that we often counsel is that, well, if you think about the things that are healthy for your heart, they're also often healthy for your brain. So for example, a balanced diet, we often talk about the Mediterranean style diet, a diet that's balanced in fruits, veggies, all those good nutritional things, healthy fats, regular physical exercise. And then sort of the part that might be harder to plan in your day, but is just as important, is staying socially and cognitively engaged. So, making sure you're spending time not only with your family, but also with your friends, because your brain has to do different types of work in a friend group than you do with your mom, right? And vice versa. Spending time doing things that are challenging you. The fact that you are here learning about neurodegenerative disease on a Wednesday night is expanding your brain and exercising your brain in a different way. So we think about all of those things together, and so those lifestyle and sort of like cognitive habits, puzzles, games, things that keep you engaged and keep you active, limiting screen time. Those are the types of advice that we give to our patients, limiting alcohol use, things like that. But as you know, we want to make sure everybody's enjoying their lives. So if you hate doing crossword puzzles, like don't do 4 hours of crossword puzzles a day. We want to make sure it's something that folks enjoy. Any other questions? Juliana, tell us more. In what way, or any specific technology coming to mind? So in terms of social media, certainly there's been data out there regarding mood disorders and sort of the social impact of social media, for lack of a better term. In terms of the effect of screen time in general or social media in general, that's a great question, both Juliana and Haya. I don't know that we've like existed with social media for a long enough time to really know. But in terms of the things that we would recommend is just generally limiting screen time so that you're spending more of your day doing things that are sort of engaging your brain in a variety of different manners as opposed to kind of being with the screen. I know it's becoming increasingly challenging in our society though, and so I'd venture to guess you're going to be seeing more about this as time goes on. But right now, I'm not aware of any data. I don't know, Mattia, if you are.
No, I was just thinking because these are such great
They're great
questions.
questions. Yeah.
The question about social media is, I think it's particularly complicated. What Chris said about screen time is absolutely true. Um, Social media is complex because I think some of it can be negative, some of it can be positive to the person. Um, if anyone's interested, there's some really interesting work that's coming out from a few centers in the States. I think Harvard is the main one, but looking at this idea of the social connectome. So how a person is integrated in their social sphere, right? And we know that having more of a widespread social connectome, which is a very fancy way to saying, having lots of support people, friends and family, having a really widespread one and diversified, meaning, you have a friend that's a friend from work, you have a friend that's a friend from your childhood, and they give you different avenues for your brain, right? Now we know that the more widespread and diversified it is, the better it is for your health for multiple conditions, including neurodegenerative conditions. So it would be interesting to see where social media falls into this, right? Because I don't think it's all negative. I do think, it can pose some challenges, but it would be something very interesting to look into that I don't think has been studied thoroughly, at least.
I'll make a plug that all of you can help us to answer these questions if you envision yourself pursuing a career in neuroscience or neurology. So if you have any questions about that at any point, Mattia and I are always happy to chat, as is Shreya, I'm sure.
Yeah, and you guys really raised some. I'm not just saying this, but I really think the questions you guys have raised are really thought-provoking. So I like how advanced your thinking is.
All right, I just want to respect everyone's time. I know we're way past our time here, but if I can go ahead and give both first speakers emails out if they're okay with it. Just if
Absolutely.
Absolutely.
any further questions. Stephanie, give me 1 second. But yeah, otherwise, thank you guys so much for coming. Thank you, Dr.
No, I'm sorry, I did that by mistake.
Oh, no, you're fine. Thank you for both our speakers for giving a wonderful talk. I'll definitely have